pumped blood by synchronized muscle contraction. On the other hand, in the case of left bundle branch block, the conduction system blocked around here, and dysynchrony is generated in the pumping. In the case of left bundle branch block, QRS and QT width in ECG is prolonged. Ejection fraction and stroke work is decreased, as shown in the figures. Cardiac desynchronization therapy is a device treatment to correct the dysynchrony by left ventricular and right ventricular electrical pacing. It is a simple and powerful technique to treat the cardiac dysynchrony, like a left bundle branch block. The survival rate of cardiac desynchronization therapy is better than medical therapy, as shown in these figures. Cardiac desynchronization therapy is invasive treatment, expensive device. However, about 30% patient of dysynchrony is non-responder. It requires optimizing the stimulation point and timing. To overcome these problems, we created patient-specific heart models for optimizing CRT. This slide shows the outline of patient-specific CRT simulator. At first, we make the patient-specific finite element model of heart and torso based on clinical data. Second, we obtained a reasonable agreement between the simulated and actual blood pressure, electrocardiogram, and echocardiography. At last, we optimize the stimulation point and timing of CRT. This is an example. He is a 6-year-old man. He suffers from complete atrioventricular block, heart psychosis, and heart failure. She have already implanted the pacemaker in the right ventricle. We obtained good agreement between the simulated and actual electrocardiogram and ultrasonic cardiography, as shown in these figures. Next, we try to optimize the CRT. The ejection fraction improved about 6% by using CRT in this patient. The simulated ejection fraction showed a good correspondence with the actual ejection fraction in the case of after and before CRT. Black line is a pre-CRT condition, and red line is the current CRT condition. CRT simulation shows that CRT protocol applied to this case was close to optimal, but further improvement, although little, to be attained. Green condition is better than current CRT, as shown in this figure. Why the ejection fraction is improved significantly in this case? The ventricular aneurysm caused by thinning of myocardium is corrected by the biventricular pacing. This is a ventricular aneurysm corrected by the CRT. For validation, we are required to prove the statistical superiority in clinical medicine for validation. You have 50 tiny examples for animal experiment. This slide summarizes the validation of CRT simulation by blind experiment. In the both figures, perpendicular axis is clinically observed improvement in the ejection fraction. On your left, the horizontal axis is simulated improvement in the ejection fraction at maximum dp/dt. In this case, we obtain the significant correction as in this figure. The maximum dp/dt is the maximum value of time derivative of pressure histories in left ventricle. You have the conclusions. Marit-scale tailor-made heart simulation could reproduce most of the failing heart pathophysiology and response to CRT, thereby providing mechanics insight into the pathophysiology of heart failure with conduction block. They are collaborators about this work. Next, I'll talk about drug discovery using UT heart. Today, I focus on cardiac safety assessment of drug effect based on combining automated patch clamp and UT heart. Tolsardeplant is serious side effect of drugs, and during the process of drug discovery, every drug have to evaluate the cardiotoxicity. Current guideline for cardiotoxicity testing insists in heart channel assay, APD measurement, and SARA-QT study. These tests have been successful in preventing serious events, but these tests are costly and may not accurately predict the risk, thereby sometimes assigning false positive to possibly useful drug candidates. To overcome these problems, a paradigm shift in cardiac safety assessment is needed. You have developed in silico assessment system for the arrhythmogenic risk of drugs using the three-dimensional hash simulator based on the finite element method. This slide demonstrates our finite element model of heart and torso briefly. Finite element model of torso and heart developed based on the 3D reconstruction of CT image. And principle in the torso model, principal origin represented by the difference of electrical conductivity, and the finite cell model of electrophysiology is embedded in the heart of finite element model. By solving the cell model, which is very complex nonlinear equations, and we can obtain the histories of ionic current. We employed two kinds of cell models for ventricular cell and Purkinje fiber cell. On your right, this is the sequence of excitation contraction in the control condition without drugs. In the cardiac muscle regime, 22 million cell models are embedded. From the body surface potential map, we can obtain 12-lead ECG. This slide shows a diagram of the assay system. This is a hybrid screening system. The dosing invitation curve of drugs were determined using the automated patch clamp system. Condition of the in silico heart model under specific the channel parameter in cell models to yield 12-lead ECG. Dosing invitation curve of drugs were determined for 6 ion channels, namely IKR, INA, ICA, IKS, IK1, and ITO. This video shows an experiment. Dosing invitation curve have two parameters, IC50 and H. H represents the slope of the curve. To evaluate the predictability of our simulator, we selected the 12 test drugs from the TDP risk category by red one. On your right, there are dosing invitation curve for 12 drug tested about 7 ion channels. Green circle corresponding to effective free therapeutic plasma concentrations. In this study, drug concentration quantified by the multiples of the ETCP unbound. We have the result. This is an example of the cardiotoxicity testing using simulator. On the upper figures, there are two rhythm beats ECG under various drug concentration at heart rate 60 and 40. In the case of verapamil, it is known as a safe drug. As drug concentration was increased, the QT interval prolonged. However, we cannot observe the generation of arrhythmia. On the other hand, in the case of E4031, it is known as a high-risk drug. We can observe the generation of arrhythmia at very low drug concentrations. Simulated 12 ECG during trusted points induced by E031 at 10 times of ETCP unbound are shown in the lower figures. The ECG waveform shows the typical case of trusted points. The trusted point is triggered by the early after repolarization developed in the developed region, as shown in this movie. This slide summarizes the result of in-silico risk assessment for 12 drugs tested. Arrhythmia risk quantified by the threshold concentrations relative to ETCP. In the high-risk drug in category 1 and 2, their drug shows a very low threshold concentration, threshold values. In the safe drug, in category 4 and 5, we cannot observe the generation of arrhythmia. There are no false positive in this case. This system can predict drug-induced arrhythmogenic risk, reliability, and efficiently. We have the conclusions. We propose the cardiotoxicity testing system combining in vitro channels assay using the automated patch clamp technique and in silico simulations of cardiac electrophysiology. The system can predict drug-induced arrhythmogenic risk, reliability, and efficiently. But this system has some problems. Our simulator have a huge computational cost, and everyone cannot use our simulator. To overcome these problems, we created the exhaustive database of ECG and various combinations of ion channels in inhibition using SYMPOSIUM at this website. In this website, if you send the ion channel data, it returns a arrhythmogenic risk, ECG, and safety margin promptly without calculation. After that, we've opened this website. Many people use. They are collaborator of this work. At last, I'd like to show the arrhythmia propagation test. The external stimulus was applied to the right ventricular apex under Sapulido administration. Sapulido is known as the high-risk drug. Premature ventricular concentration involves the ventricular fabrication through the torsade points. I did not change the parameter during the calculation, but the excitation propagation is automatically changed to ventricular fabrication. Under the condition of ventricular fibrillation, heart cannot pump the blood.
Sorry, Prof. Okada, 1 minute left for your presentation.
Thank you for your attention.